you, Bombay Spine Society, for giving us opportunity to present our work on clinical and radiological outcomes following the bedrock technique to enhance spinopelvic fixation. So if you fix L4 to S1, there is 168% added stress on the sacro-iliac joint, and if you fix only the L5S1 level, there is a 52% added stress on the sacro-iliac joint. In the current literature, the incidence of sacroiliac joint pain following the long fusion is between 12% to almost 35%. This is the study done by our group, which has already been published with 317 patients, out of which 38 patients developed a new onset sacroiliac joint pain after the long fusions, and the incidence was almost 11.9%. The current complications of iliac screw while fusing the patients to the pelvis are up to 45%, 44% incidence of screw loosening, usually asymptomatic, infection up to 20%, prominent or painful screws, difficulty connecting to the adjacent construct, neural or vascular injury, acetabular penetration, and sacroiliac joint dysfunction. So there are few advantages of S2 AI screws, which has been introduced since last few years. I will mention the technique in short. The S2 AI technique uses a starting point in the sacral ala between the S1 and S2 and neuroforamina, directed towards the anterior inferior iliac spine, allowing inline anchors without additional connectors or dissection. It allows the iliac crest bone graft harvest, and it crosses the sacroiliac joint and reduces the SIJ movement. But this screw, if used alone, it has a lot of complications, almost 2 to 3%, including SIJ pain, loosening of the S2AI screw, set screw dislodgement, neck fracture, shaft fracture, and requires revision in up to 1.6% of the patients. So this technique of SIJ fusion, it includes the one cage and the S2AI screw on each side. So this study showing the S2AI screw when used with the A-leaf and the bedrock technique, there is decreased bending movement and decreased range of movement at the sacroiliac joint compared to all the available techniques. I'll show you this with one example. This is a 68-year lady with adult degenerative scoliosis with PILL mismatch of about 15.4 degree with severe bilateral leg pain and back pain and bilateral sacroiliac joint pain. Her scoliosis was around 52.9 degrees, and there were multiple levels of foraminal stenosis, as we see. So we planned all these patients using the surgery map. We did all the cases in 2 stages. In stage 1, we did the anterior procedures, O-leaf and A-leafs, by 2 different approaches. And in stage 2, before doing the stage 2, we do a whole spine X-ray to assess the balance, and also the UOS scan. This is the post-operative X-ray showing the good correction with well-balanced spine on the UOS scan. And intraoperatively, we use 2 guide wires. So this is the tiered of view showing the inferior guide wire is for the S2AI screw and the superior guide wire is for the cage. And we used navigation for all our patients. This is the technique. This is for the S2AI screw, and the pink one is for the cage position. Intraoperative view in C-arm. Then this is the view showing the navigation guided screw and the cage position. We check on the C-arm the position of the screw and the cage. The similar steps carried out for the contralateral side of the sacroiliac joint, and this is the intraoperative C1 picture showing the position of the cage and the S2AI screw. So in this study, we used total 15 patients. Preoperatively, EQ5D VAS, ODI, VAS questionnaire scores were obtained in all the patients. The enhanced spinopelvic fixation using the bedrock technique were performed in a single tertiary care specialist center at Royal National Orthopaedic Hospital by two senior spine surgeons. All the implants were inserted using the computer navigation. We prospectively reviewed patients' reported outcome measures at 6 months and 1 year follow-up. CT scans were performed in all the patients at 12 months to assess the fusion rate, and all the patients had a minimum 12-month follow-up and were assessed for SIJ pay. So out of all the patients, 10 patients had degenerative scoli with positive sagittal balance, spondylolisthesis and positive sagittal balance in 2 patients, and 3 patients were like revision spines, revision surgery for previous flat back fusions and metal failures. So we included total 15 patients. At 1 year follow-up, there is significant improvement in the clinical parameters of the patients. And for fusion, 15 out of 15 patients had a CT scan at exactly 1 year post-operatively. The CT scan of all these patients revealed good evidence of fusion at 1 year with bone growing through the sacro-iliac joint cages. There was no case of distal implant failure or evidence of the screw loosening. So to conclude, the clinical and the radiological results from our study reveal that the use of triangular sacro-iliac joint cages in addition to the S2A screw, which is we call as a bedrock technique in long construct adult deformity surgery, results in the good outcomes with no mechanical failure of spinopelvic fixation. Thank you.
Thank you, Dr.